Hello everyone. In today's lecture, we will be discussing anemia. Anemia by definition means a reduction in RBC count, right? So how do we determine that? Well, we either have to measure the hemoglobin concentration in the blood or we're going to use the hematocrit. The hematocrit is basically a percentage of the blood that's occupied by RBCs. That is the hematocrit. If you don't have the hematocrit, but you do have the hemoglobin concentration, there's a way you can calculate it, and that is multiplying hemoglobin concentration by 3, and that gives you an approximate of the hematocrit of the patient. So the general signs and symptoms of anemia are highly variable. They depend on the severity of the anemia, how anemic is the patient, the rate of the anemia, how long has it passed since the anemia has developed, how long has it taken for this anemia to develop, has the patient had any compensatory mechanisms to overcome the anemia, the O2 demand of the patient. Some patients have pathological conditions which that makes them require more O2. However, the most common signs and symptoms would be fatigue, being tired, dyspnea, shortness of breath, headache, neurons, they require a lot of oxygen, palpitations and tachycardia, both the hearts trying to beat faster and harder to get the blood out to the tissues, pallor, which is mostly noticeable in the conjunctiva. Some patients with anemia will have an underlying disease, like patients that have acute bleeds, right? They can show hypotension, syncope, passing out, orthostatic lightheadedness. In cases of hemolytic anemia, there will be jaundice available. In case of a GI bleed, there may be blood and stool. So the two compensatory mechanisms that the body comes up with is increased cardiac output, basically trying to increase your stroke volume. You get the palpitations that we previously mentioned, heart rates goes up. You also have an increased oxygen extraction ratio, means the tissues, since they're hypoxic now, are going to extract more oxygen out of the blood. So we have an anemic patient. When do we give a blood transfusion? The answer is in two conditions. One, if the hemoglobin concentration of the patient drops below 7 grams per deciliter, it's time for a transfusion. If the patient has an underlying pathological condition that increases O2 demand, such as coronary artery disease or any type of cardiopulmonary disease, that's the time to give a blood transfusion. Now, there's different transfusion types, each depending on the situation that you're in. However, we'll go through these very briefly and give you an introduction. One is packed red blood cells or packed RBCs. There are no coagulation factors or platelets in there. However, when giving it, we mix it with saline to infuse it faster. We don't give lactated ringer because of calcium present, and that will cause coagulation. Each unit of packed red blood cells will increase hematocrit by 3 to 4 points and is typically given over a period of 90 to 120 minutes. We always perform a CBC afterwards. Whole blood is given to patients with a massive blood loss. The ratio is going to be platelets 1 to 1 to 1, which is 1 platelet, 1 fresh frozen plasma, and 1 packed red blood cells. Now keep in mind, when we're giving whole blood, we typically want to make sure it's warm, especially given in large quantities, because we don't want the internal core temperature of the patient to drop by giving them cold blood. Fresh frozen plasma is given to patients with high PT and high PTT numbers, or patients with coagulopathies and deficiency of clotting factors. There are no clotting factors or any type of platelets present in fresh frozen plasma. There are no cells in there either, no red blood cells or no white blood cells. We also give it in times when vitamin K takes time to work its magic, or in patients with liver failure, which again affects vitamin K. We follow it up with PT and PTT afterwards. Cryoprecipitate basically has factor VIII and fibrinogen in it. It's given for hemophilia type A. Or in cases of low fibrinogen factors like the disseminated intravascular coagulation. That's a case where you can give it as well. Platelets, typically given when the patient has a very low platelet count, and 1 unit can increase the platelet count by 10,000. So how do we diagnose anemia? Well, the patient comes to you, they have a low hemoglobin concentration or low hematocrit. What is the next thing we look at? That is the reticulocyte index. Well, what the heck is a reticulocyte index? Well, they give you a reticulocyte count, right? But the thing is about that, it's expressed as a percentage of the total RBCs. So when a patient has anemia or lower RBCs, you have to correct the red count. The way you do that is with a formula. The formula is basically the percent red count that they give you multiplied by the patient's hematocrit over normal hematocrit, right? That gives you a number. If that number is over 2, the red count is elevated. If it's equal to 2 or less, then it's normal, right? It basically means that when you're losing RBCs, let's say hypothetically we're going to this situation where we have an elevated red count. The red count is higher. The immature red blood cells inside the blood are higher than normal, right? This means that you're losing RBCs faster than you can replace them. Okay, that's why you have so many immature RBCs in there. Now, this could happen in either way. It could happen when you have a massive blood loss, right? Or you can have hemolysis, basically red blood cells inside the vessels getting damaged. Now, if you're suspecting hemolysis, you're going to check for some of these things that are inside the RBCs that leak out when they're destroyed. One is haptoglobin, one is LDH, and bilirubin. If all of these are normal, then most likely the patient has a blood loss, and then you have to check for the source. Now, if the patient has a normal ret index, which is equal or less than 2, then you have to look at the mean corpuscular volume. The mean corpuscular volume, if it's less than 80, it will be microcytic anemia. If it is between 80 to 100, it'll be a normocytic anemia. If it is over 100, that means that it is a macrocytic anemia. In the case of microcytic anemia, we have to check out for iron. Microcytic anemia is typically a production problem. So we gotta, either we don't have enough iron or there's something going on, right? We don't have the proper globins to make the hemoglobin. So there's something going on there. There's a production problem. In the case of a normocytic anemia, it could be aplastic anemia, it could be bone marrow fibrosis, it could be tumors or anemia of chronic disease, it could be renal failure, where erythropoietin is not being secreted properly. If we have a macrocytic anemia, we go to look at vitamin B12 and folate in DNA problems. So if it's normal, that means the patient most likely has liver disease. If it's abnormal, it's diagnostic for what they call megaloblastic anemia. Okay, so let's discuss microcytic anemias. And keep in mind these anemias have a mean corpuscular volume of less than 80. However, they have a normal red count. Iron deficiency anemia is the most common microcytic anemia. Its most common cause is chronic blood loss. Now, in which patients do we see chronic blood loss? Well, if it's a menstruating female, I would assume that menstruation is the cause, right? But however, it's a postmenopausal woman, or if it's an adult male, then menstruation is not there, so you're going to suspect a chronic GI bleed. There are certain cases where iron requirements are increased or there's low dietary iron. In those cases, you can also see iron deficiency anemia. One of those is pregnancy, and a pregnant patient requires a high amount of iron per day. Babies and toddlers, they're growing, so they're going to need more iron. Adolescents are also growing, but adolescent female also menstruate while they're growing, so they're at most risk. All right, so diagnosing iron deficiency anemia. How do we diagnose it? Well, we do an iron studies. First off, iron's going to be low, obviously, in iron deficiency anemia. What else do we look at? We look at serum ferritin. What the hell is ferritin? Ferritin is just an intracellular protein that sequesters iron and then systematically releases that iron in a systematic manner. Some of that iron is actually secreted into the plasma. So serum ferritin levels is a good indication of iron stores. If your iron stores are depleted, you are losing ferritin. Your serum ferritin will be lower. Increased total iron binding capacity, transferrin levels. Okay, what is transferrin? I call transferrin the bus, right? It's a glycoprotein that's produced in the liver. So your liver produces transferrin, and then it's the main vehicle by which your iron is transported in your blood. Now, consider this a bus. This is your transferrin bus. It has 100 seats. Out of these 100 seats, if 33 seats are filled, it's called saturated. So at 33 seats filled, your transferrin is pretty much saturated. Now, if you start, let's say you have anemia, an iron deficiency anemia, a lot of this iron is going to leave the bus to go into the blood and get to the bone marrow where you can produce more red blood cells. So this percentage will be lower. So your total iron binding capacity will go up because now you have more seats available on the bus. So when they tell you there's an increased TIBC, there just means that transferrin is losing its iron, and that iron is basically going to compensate for the anemia. Now, what if you have low transferrin or high transferrin levels? You'll have high transferrin levels when you have anemia because your liver is going to produce more buses to get more iron to the tissues that need them, right? To produce more red blood cells, which basically means your bone marrow. So you're going to have a decreased transferrin saturation. Remember, when the people leave the bus, when the iron leaves the bus, now your saturation is, let's say, at 20. So only 20 seats are filled by iron. The other 13 irons left because you're anemic. And obviously you have decreased serum iron. If you look at a peripheral blood smear of a patient with iron deficiency anemia, you're going to see microcytic, small RBCs that are hypochromic. They're very pale, right? This is a moderate case, and later on, if it becomes very severe, you see what happens here. There's hardly any hemoglobin in those RBCs. The gold standard to diagnose iron deficiency anemia is actually bone marrow biopsy, but it's only rarely done, and only done when there is no identifiable source. If the patient is an adult male, or if it's a postmenopausal woman, or a patient that is not menstruating, you suspect the GI bleed. If you suspect the GI bleed, then you have to check, do a guaiac stool test or do a colonoscopy. Okay, in this particular slide, we're going to discuss iron studies in microcytic anemia. Now, keep in mind that anemia of chronic disease often presents as a normochromic normocytic anemia, but in this case, if it presents as a microcytic anemia, this is what we look at as far as the iron studies go, right? Okay, so in iron deficiency anemia, what do we expect the serum iron to be? Obviously, the serum iron is going to be low. We're iron deficient. What about serum ferritin? Remember, ferritin was the protein that sequestered iron in the body and then released it back in a systematic fashion. It is also a good indication of iron stores. Well, if we start using all of our pocket money, then where do we hit next? We hit our bank account, our stores, right? So the stores are going to be low as well. Total iron binding capacity will be increased. Why? Because remember that vehicle that we talked about? The transferrin vehicle, the protein, the glycoprotein that is made by the liver that is responsible for carrying iron around the blood. Well, that vehicle is going to be produced at a larger quantity by the liver when you're iron deficient to get more iron to the tissues, as well as dumping more of the passengers. Remember, we said at 33% we consider the transferrin saturated. Well, if you start dumping passengers, you're going to have more seats available, and more seats means total iron binding capacity goes up. RDW is basically red cell distribution width, right? It's the varying sizes of your anemia. Like, let's say you have an anemia that the cells are in this category. They're all about 75 or 70 MCVs, right? Their mean corpuscular volume is around 70 on all of these cases. But then you have an anemia like this. There's a variation in size, right? There's a production issue which causes a variation in size. This is classically seen in iron deficiency anemia. So this is one of the things that you can remember. If you have an RDW that's increased, then you're going to think of immediately as iron deficiency anemia. In most cases of other microcytic anemias, it's actually normal. I know it says normal or increased here, but it's usually normal. Anemia of chronic disease, serum iron is going to be low because you're using the iron, but the problem is the stores are going to be okay because you're not actually iron deficient. Total iron binding capacity goes down, and the RDW is normal. In thalassemia, it's a globin chain problem. Really has not much to do with iron anyways, right? So your iron's going to be high because you're probably not producing enough hemoglobin. So you might have an extra little bit of iron left around, laying around. All right, so serum ferritin will also be normal or high. Total iron binding capacity will be normal. You're not iron deficient. RDW is typically normal as well. All right, so before I get into treatment, I'm going to throw a couple of clinical pearls out there. In elderly patients, if you have a patient that's 60, 70, 80 years old, and you have iron deficiency anemia, the first thing that you have to rule out is colon cancer. It's no longer the GI bleed that we're concerned with. If the patient's that old, we need to check for colon cancer. Also, iron deficiency anemia has a couple of things associated with it. Pica being one of them, that's craving of non-food items, and then pagophagia, which is the craving of ice. That's typically seen in pregnant patients, but iron deficiency anemia patients also enjoy that as well. So the treatment is oral iron supplement, which is ferrous sulfate. Menstruating women can receive it at any time. Postmenopausal women, determine the cause because their anemia is not because of menstruation, right? The side effects are going to be constipation, nausea, and dyspepsia. Parenteral iron replacement, iron dextran, it can be administered IV or IM. It's rarely necessary because patients actually respond to oral supplements. Transfusion is not recommended unless the anemia is very, very severe or the patient has an underlying cardiopulmonary disease. All right, let's discuss thalassemia. Thalassa means the sea. It's from Greek origin. Hema, blood, and basically it's because people around the Mediterranean are most commonly seen to have thalassemia. Some people in the Middle East and India also have it, but mostly it's seen in Mediterranean and Jewish populations. It's inherited. It's a defect in the alpha or beta globin chains of hemoglobin. The severity depends on the number of alleles deleted or mutated. It's completely dependent on the mutation. If you have more alleles that are deleted or mutated, you're going to have a worst case scenario. In some cases, it's asymptomatic. In some cases, it's fatal. And we're about to go through those right now. All right, let's discuss beta thalassemia. Basically, when there's a defect in the beta chain synthesis, right? If the beta chain synthesis is decreased, you're going to have beta thalassemia, and there's two types. Now, first off, let's look at hemoglobin real quick. The adult hemoglobin, or HbA, hemoglobin of adults, is made up of, it's a tetramer. So there's 4 globin chains. 2 of those will be alpha, and 2 of those will be beta. There's also another minor type of adult hemoglobin called HbA2, which is 2 alphas and 2 deltas, correct. Now, what happens is when you have less globin chains available, these alpha chains will go and bind to the RBC and they'll start causing membrane damage. It's mostly seen in Middle Eastern, Mediterranean, and Indian ancestry. There's 2 different types, as we said. If both alleles are deleted, you're going to have a thalassemia major or Cooley anemia. It's a homozygous deletion or homozygous mutation. Beta thalassemia minor is a heterozygous. Only one allele is actually affected. All right, let's discuss beta thalassemia major. Remember, we said this is when both alleles of beta chains is actually deleted or mutated. The patient's going to have severe anemia when? In late infancy. Why? Because remember, the fetus has a different hemoglobin. It's called HB fetus or hemoglobin of fetus. It's comprised of 4 chains, 2 alpha chains and 2 gamma chains. If there's anything you need to remember about this, it is that it has a higher affinity for oxygen. Why is that? Because while the fetus is in the womb, it is competing with the mother's blood for oxygen. It is competing with the mother's hemoglobin, which is hemoglobin A. So having a higher affinity for oxygen allows it to pull the necessary oxygen across the placenta into its own tissues for growth. Patients will have massive hepatosplenomegaly, right? All these truncated proteins are being built up in the liver, causing inflammation and all kinds of issues. You'll get jaundice and dark urine from the hepatosplenomegaly or liver issues. You're going to get a bone marrow expansion, right? You're anemic. You need to get oxygen to the tissues. Your bone marrow is going to start producing more RBCs, and the way it wants to do that is by increased bone marrow. Now, the classic sign that we see is called crew cut on X-ray or hair on end design. You see these are basically just expanded trabeculae. Trabeculae means walls, right? They're expanded walls that have bone marrow in them. You just have more bone marrow, and that's what it looks like in an X-ray. You can also see, if you look closer here, all these lines, these are just trabeculae here that are filled with bone marrow and trying to compensate for the lack of beta chains. You're going to have growth retardation and failure to thrive. The brain's not getting enough oxygen properly, right? So it's not going to thrive. You're going to have, if it's untreated, it's going to progress to congestive heart failure and eventually death. We diagnose this via electrophoresis. We just take a gel with different holes in it, and then we run the patient's sample through the holes, and as it goes through at different sizes, the different proteins get stuck. By that, we can determine what the patient's going to have. Obviously, HbA will be down, but the minor adult will be up, because remember, this was alpha 2, delta 2, right? Yes, that's correct. Now, HbF was alpha 2, gamma 2. So since it can't produce alpha 2, beta 2, it's going to start producing other types of hemoglobin. If you look at the peripheral smear, we previously spoke about it. It's microcytic hyperchromic with possible target cells. We're going to discuss those in a minute. The treatment for beta thalassemia major is frequent RBC transfusions. And remember, when a patient always has frequent RBC transfusions, there is a chance of hemochromatosis or depositing of iron into tissues that causes inflammation and damage to those particular tissues. All right, so before I get into beta thalassemia minor, let's discuss what a target cell is. First off, the name is actually kodocyte. That's the proper name. Kodo means bell, cyte means cell, so a bell cell. Why do they call it that? Because when you look at it on electron microscopy, you see that this little portion in the middle is actually very raised, and there's an indentation around it, something like that. It looks like a bell to a certain extent, right? And that's why they call it kodocyte. Now, when do you have target cells? Anytime that there is an increased surface area but not enough hemoglobin. So hereditary spherocytosis, you get G6PD, you have where these cells are not removed properly from the body, when you have spleen problems like an autosplenectomy of a sickle cell patient, right? When you have liver diseases where you can't produce enough heme, right? You don't have enough hemoglobin if you can't produce heme, so you're going to have not enough hemoglobin. You're going to have a decent sized cell but not enough hemoglobin. When they process it for a peripheral smear, it starts to look like a target. That's why they call it target cell on peripheral smear. But in reality, they actually look like a bell when you look at it on electron microscopy. This is when only one allele of the beta chain is affected. It could be asymptomatic or a mild anemia in patients. The diagnosis is just like the beta thalassemia major, is a hemoglobin electrophoresis. On peripheral smears, you're going to see hyperchromic microcytic RBCs. There is no treatment necessary because typically it's either asymptomatic or it's going to be very mild. So alpha thalassemia, alpha globins have 4 loci, 4 alleles, right? Unlike beta thalassemia, which only has 2. So severity of symptoms dependent on number of loci mutations. How many mutations are there? That's going to be an issue. Silent carriers, and when there's only a deletion of one of the loci. Out of 4 alleles, only 1 is actually affected. The patient is typically asymptomatic. They're going to have a normal hemoglobin and hematocrit. There's no treatment because most of the times you're not even going to diagnose them. Alpha thalassemia trait or minor is when there's a deletion of 2 alpha loci. You're going to get a mild anemia. The patients are going to have microcytic hyperchromic RBCs, but remember their serum iron levels will be typically normal. No treatment is actually necessary for these patients as well because it's very, very mild. Continuing on with alpha thalassemia, we have the next one is HBH disease, which is mutation deletion of 3 alpha loci out of 4. So 3 loci out of 4 are deleted. You're going to get a varying severity anemia. A patient could be extremely anemic that requires transfusion, or a little bit less that doesn't require transfusion. The diagnosis, like other thalassemias, is hemoglobin electrophoresis, where you're going to get HBH. Peripheral smear, microcytic hyperchromic anemias, but the iron studies will be typically normal. Remember that. Some patients are going to be transfusion dependent with an increased level of hemolysis, especially in the cases of infection when there is a physiological or pathological stress to the body. Mutations of all 4 loci is incompatible with life because the patient cannot produce hemoglobin properly. Remember, the fetus hemoglobin was alpha 2, gamma 2, right? So if you can't produce alpha, you can't basically produce anything. And this is where you get the beta 4 chains, or all 4 betas coming together to produce a hemoglobin that is pretty much ineffective. The patient typically dies in the womb or shortly after birth. It's called hydrops fetalis. And here we have all the sources that I use for this presentation. I hope you enjoyed the presentation and learned something. I learned a lot while making it. Thank you.